Hello? Oh. Sounds good. Of course. Bye. Well, should we get started? There we go. I think we'll have a few people are coming in a bit late, given the conditions of our travel network. Although the roads coming out from Spokane were pretty decent. I don't know what they were coming from. Kittitas County, were they pretty good?
Crystal clear and bright and sunny until I got 3 miles from here.
All right, so no excuse if people don't show up. There's no snow on the road, so we'll hold them accountable at the next meeting. For those of you who don't know me, I'm Patrick Jones from Eastern Washington University's Public Policy Institute. I've been your fearless facilitator here for a couple of years, and today I think we've got a very good meeting, a very good set of learning tools lined up. Although part of it's some of the things that my shop at Eastern is doing, so don't want to have too much self-promotion there. As we're going to start, as we usually do, by introducing ourselves and our organization. And I don't have anything really catchy to ask you to say. You're welcome to add anything you want about what's happening in your organization's life, within reason, over the last month. I will point out that I will also say it's Happy New Year. I didn't say that last month. Because it is Chinese New Year.
Gongxi, gongxi.
Yeah, Xin Nian Hao. And it is the year of the pig, the year of the boar. And in contrast to a couple of years ago when we had the year of the monkey, where I thought we had actually quite a bit of sort of lessons that we could take from the year of the monkey and the monkey's attributes. The boar doesn't really hold that much promise for us this year, I don't think. The boar is known to be generous, and sort of a harbinger of wealth, but also somewhat lazy. And I don't think that really characterizes anybody in the room, right? So we won't go into year of the boar that much. But I did want to say Happy New Year, a bit late, started a couple of weeks ago. Or as the Southern Chinese say, Happy Spring Festival. So with that, I just want to ask, are people, since it is Spring Festival time, are people pretty happy with the snow shoveling they've been doing? I certainly have in Spokane. I did it yesterday before I came down, and I'll do it when I arrive in Spokane tomorrow night. So, but for those of you in Yakima, my heart goes out to you. I just can't believe the snow you've got, and I'm sure you follow what's happened to the livestock in the county. That was really quite stunning to see that kind of damage. And I'm always amazed when the Tri-Cities is cold. I'm always amazed when the Tri-Cities has anything resembling white stuff on the ground, because that's not my image of your community. So different times. So why don't we go ahead and we'll start as we usually do with the back row, and I'll start with this young man there in the gray sweatshirt, and we'll just sort of wend our way through the rows. And if you'd speak up, please. Okay.
I'm Bethany Higgs, the assessment coordinator of Springfield Health District.
Oh, we need to talk.
Okay. Good morning, my name is Lisa. I work with Molina Healthcare and I do the community engagement. In Middleton, Computational Health Association.
Welcome.
Cindy Campbell.
Kirk Williamson, then Director of Community Health Alliance.
Dina Otis, Lord Health. for the really good help, and thank you for the work.
Yes.
Build a recap.
Jill?
Veronica Gutierrez, Tri-City Community Health.
Kevin Martin, Kittitas Valley Healthcare.
Matthew Campbell, Lutheran Community Services.
Bonnie Bachelor, Board of Health, and Greater Columbia.
Okay.
Ryan Karstack, Richland Fire Department. Garrett Milton, Kettle Fire Department.
Diane Campos, Jackson Neighborhood Health Services. Michelle Sullivan, Jackson Neighborhood Health Services. Lee Passer from Jackson Neighborhood Health. Diane Hammond, Greater Columbia. Becky Coleman, Greater Columbia.
Ruben Peralta, Greater Columbia.
Wes Lucky, Greater Columbia.
Carol Winder, Greater Columbia. Ashleen Fernandez, Greater Columbia. Jenna Shelton, Greater Columbia.
Martin Sanchez, Greater Columbia.
And Dan Ferguson with Valley Health Center of Excellence, opposed to Yakima Valley College, on the board representing workforce, and also attending today representing the Yakima County Healthcare Coalition. And I have to say, 2 weeks ago, I was celebrating Chinese New Year in Taiwan, and playing tennis in 80-degree weather. So,
That's right, called Spring Festival.
right, this is a bit of a shock.
Lauren Thompson, Greater Columbia.
Okay, and let's go to those on the line. We have a few, right? Yes. Oh,
Tom?
would you like to introduce yourself?
Here as an individual.
That's quite all right. Okay, so not all at once, but those of you on the line, if you wouldn't mind introducing yourselves.
Judy Miller, Columbia County Health System.
Thank you, Judy.
Berta Lopez, Virginia Mason Memorial in Yakima.
Bertha.
Nikki Kidder, Chaz Health.
Hi, Nikki. Are you in Spokane?
I am in Lewiston.
Okay.
Martha Lemon, Columbia County Public Health.
Hello, Martha.
Shane McGuire, Columbia County Health System.
Hello.
Mandy Olson,
Why don't we start with Mandy? Go ahead, Mandy.
Mandy Olson, Kittitas Valley Healthcare.
Thank you.
Corey Blythe, Aging and Long-Term Care.
Hello, Corey.
Amy Norton, ESD 105.
Hello, Amy.
Amy Person, Benton Franklin Health District.
Dr. Person.
Deb Watson, Pullman Regional Hospital.
So bad.
Kelly Sanders.
Could you repeat that, please?
Kelly Sanders with Pullman Family Medicine.
Okay, Kelly.
And Virginia Janin, Aging and Long-Term Care.
All right, Virginia. Okay. Anybody else?
Yes,
Marcia Baden.
Okay. Flip a coin.
Marcia Baden, Garfield County Hospital.
Okay, Marcia.
Teresa Quate, Palouse Medical, and I've got TJ Osborne with me and Kim Nygreen, all from Palouse Medical.
Oh, great. Okay. Well, thank you for being on the line. All right. I think we've gone through the list of 20. So thank you for checking in with us, and we will get started then with our report. We'll start with Ms. Moser, and let the group know what's been going on with your staff over the last month.
Well, first of all, everybody should go out and grab a cup. This is part of our attempt to bribe you as we're going through today's evaluation of Greater Columbia GCACH. I guess I would do that quite that on. So we just thought it would be really nice. We have gone to other events, and this is a way to put, healthy our cups, so we thought we would do that today. I'm just gonna have each person who wrote their article take you through our report, and the first up is talking about the opioid research network.
So this month we have put out a RFP for a opioid resource network management. Oh, sure. And the network manager has the responsibility of project oversight and to ensure all network organizations are working in coordination with the terms of the project, contract, and deliverables. It's going to be for Benton and Franklin and Walla Walla counties. And so the RFP is due back to me by the 22nd of March. And if you have any other questions, you can reach out to me directly. My email is there. And since I'm already here, I'm just going to go ahead to my other articles that I have. The next one is, so we are having a regional summit on opioid use disorder and trauma-informed care. And it's going to be held in Yakima at the Pacific Northwest University. And it's going to be June 19th through the 21st. The 19th will be a public event for the public, and it's going to be from 5 to 7. And then the next 2 days there'll be four tracks. So you'll be able to choose a different speaker that you would like to go to. The registration, we're still in the process of getting the registration and the website created, and so once we have that done, we will send it out to everybody so that everybody can be aware of that and be able to sign up. In here, there is a list of people who should attend, and pretty much anybody that is part of our organization should, try to make it. I think it'll be a good seminar and summit to cover in trauma-informed care and also the opioid use crisis that we're having. Oh, and it's part of the Learning Collaborative, so those going through practice transformation, it will be a requirement to attend. So, so just reach out to your practice transformation navigators if you have any questions about that. The next article that I'm going to talk about is behavioral health providers move fully into integrated managed care. So they moved into integrated managed care as of January 1st. Things seem to be going pretty good so far. We've been having calls on Mondays and Wednesdays and Fridays, and to address any issues that have been arising. And then starting in February, the 28th will be the first early warning system webinar that they're going to be having. And so that will be able to, Healthcare Authority has put together different indicators that they're tracking. And so that will be the first one that they're going to be reporting on. So there's a call in for it. If you do not have that information and would like it, you can reach out to me as well.
Who's next? Becky? Yeah, wow.
Cool.
Good for you.
Good morning, everybody. So the portal payment, the table that I normally report on, I changed it up a little bit. I don't know. So normally we reported out on what was paid out on the contract, and you all recall last year we did the letter, the LOI and the CSAs, and so we were reporting on all those, but I'm happy to report that all those payments have been made. So we've changed the spreadsheet a little bit. So now we're showing you the categories that are actually in the portal and what we pay from. So you can see that the first one's the community health fund, and that is for our third-party administrator contracts, which we have paid paid out to one of our third-party administrators for 2 different projects that they're working on with Ruben. And then our integration incentives was our BHO contracts from last year, which Diane was talking about as Project to Go, very exciting. And then our project engagement, and that is our current practice transformation contracts that Martine and Jenna and Sam are working on it. So then it shows that our total for 2018 payments out of that portal were just over $3 million. And then the total so far for 2019 are about the same. So we're pushing money out and we feel really good about that. Anybody have any questions?
Thank you, Becky. Okay, Mr. West.
Sure.
Hi, I'm Wes. Just a brief update about some of the health information technology initiatives that we have in place. We've talked before about CSI, which is the vendor we're working with to put together our IT solution for provider reporting relating to milestone deliverables for those organizations that are going through practice transformation on a quarterly basis. They will be doing reporting to show completion of those deliverables. There'll be a web page that will be developed eventually. We're hoping by the end of March for providers to do their reporting. There are 3 other ACHs that are using CSI solution for their reporting. Because of the way that we've organized our practice transformation efforts and the included reporting is so much different from what the other ACHs are doing. There's going to have to be a custom build that's tied to this, which extends out the timeline. Unfortunately, it also adds to the cost, but the final solution for this for qualitative and quantitative reporting is really going to be great. CSI is also going to provide us with a landing page to include information for each organization to create directories to load up their information relating to their practice transformation efforts, such as their MEHAPs, PCMH assessments, their change plans, and other documentations that the practice transformation team works with the organization on. So this will be a great resource for them. There'll also be information there about our learning collaboratives. We hope to upload a lot of resources to help facilitate this entire process. There'll be a calendar, an RSS feed, and a lot more. We've talked about this before, and we're really excited about it. It's just taking a little bit longer than we first anticipated. We've also talked about direct secure messaging. In general, interoperability is a very, very important part of this work, both provider to provider and provider to community organization. So direct secure messaging is part of that. It's simply an electronic exchange between provider organizations. For those provider organizations, it will be linked up to their EHRs. For those that have direct secure messaging embedded in their EHR, such as Cerner, they won't have to worry about this. For those that don't have this technology, we expect that they will upload this. They can either work with our vendor DataMotion, who we've vetted through a competitive process, or they can choose their own direct secure messaging vendor. However, there is an expectation that they will get a vendor, and the funding for this comes from the base population health funding that we have given to the practice transformation organizations. Also, we will be paying for EMS organizations to have this technology too. They're a very important part of this work. So we'll be providing funding for implementation and maintenance of this software at least through the end of the practice transformation process for those EMS vendors, or organizations that want to take this on. Not in the report is an update on the Health Commons. As we've talked about before, GCACH has been doing this work for several months now. We're at the point where the pilot project has pretty much come to an end, and what we're waiting for are a series of agreements to be formed, one between the Greater Columbia and the GCACH County Health Network. There are also business associates agreements that have to be formed between KCHN and all the partners in that network. This is a requirement. As well, there is a consent sign-off that has to happen to allow 42 CFR Part 2, which is a legal requirement for those individuals, substance use disorder, to go on that and have HIPAA protection. So we have a template for that last agreement that had approval through the State Healthcare Authority, through their compliance officer. So we're very comfortable with that, integrating that into the Health Commons technology that's there. so that when patients sign on, they can sign on for a year, or actually they can sign on for their lifetime. So there isn't this endless approval process by the patient to come onto the Health Commons. It's very exciting. So once those agreements have been fulfilled, we will go ahead and then put that demonstration technology into full production mode. As well, we expect that once the Opioid Resource Network RFP comes into conclusion, simultaneously we will begin a Health Commons project with whoever the network manager becomes. Does anybody have any questions about that? Okay.
Thank you, Wes.
For those of you that were here last month, Adam Asby from Pierce County ACH came and talked to us about the experience that they had when they went back to New York and understood what disrupt meant in New York and what the investment structure looked like. It was really interesting going back and reviewing their PowerPoint presentation because I caught some things that I hadn't heard him say because he went through it pretty quickly. But the way that they laid out their district program is that they first started with PCMH. They contracted with 25 organizations representing over 100 providers. So what struck me is that we are very much in sync with that. And they called that kind of the first wave of activity. And I think you're starting to see now that we have gotten that wave of activity under our belt. Greater Columbia is branching out and doing some other really exciting things. Hosting the opioid summit, having addressing the technology needs. And we're also hosting a housing summit. So I'm on page 3 now of your report, just to talk a little bit about what Greater Columbia has been asked to do, which is to gather our community together, especially those that are involved in housing, to talk about how are we going to address supportive housing needs. The Tri-Cities really lacks supportive housing, and supportive housing means housing for people with chronic mental illness or people that just need a special level of care that they can't get otherwise. And so we really do need more inventory of that. And so we are hosting a housing summit on March 19th. And so the exciting thing about this is that GCACH Community Bank has reached out to us to say, can we be a part of this? And I think we're going to start seeing more of these opportunities as we're going into your communities to do similar things. So now that we have a little bit more capacity, please address, ask one of the staff if you have something that really needs to happen in your communities, and maybe we can help you set that up. So that will be March 19th. We're lucky enough to have Rob McCann, who is the Executive Director of Catholic Charities in Spokane, that will be coming down and telling us how they have built their housing projects in Spokane. He's done 5 of them so far. And so he's going to be talking about how they were successful. We'll have our own Rhonda Hutt talking about Yakima Neighborhood Health Services and how they've been addressing supportive housing in Yakima. Yakima's done some amazing things. In fact, that's why she's not here today, is that she has a meeting with Congressman Newhouse about some of the fantastic things that YNHS is doing. So you're more than welcome to come. We hope that this produces a level of enthusiasm and community support for this kind of endeavor, because when push comes to shove at the end of the day, there's always people that are opposed to these kinds of projects. So we want to make sure that we show that community support to the officials that will be invited to the meeting. Thank you.
A microphone, it makes me want to karaoke. Any requests? Yeah. Well, Greater Columbia is also addressing the social determinants of health to support our projects. As we know, social determinants of health are 80% of what determines our health. And the way we're addressing that, we allocated almost $2 million through 2020 to address social determinants of health. 1.4 million of that has been allocated to the 6 local health improvement networks, and they went through a process to determine which social determinants are priorities in their regions, and which we're going to have three LIMs talk about their process later on today. The remaining $600,000, we are allocating it to a ACE's resiliency media campaign, an awareness campaign. We're trying to emulate the media campaigns that for many, many years we've had in regards to smoking, AIDS, and seat belts. We're trying to get some of the success those media campaigns experience. Last month, the Communications Committee approved for us to form a task force. They provided me with 37 names, which Joyce Newsom over there did a great job. She provided like half of the names. So far we have about 20 people either confirmed or tentative to be part of the task force. And the purpose of the task force is for them to help us to ensure that we are targeted, that we are focused, and that we are sensitive, demographically sensitive, cultural, racially sensitive to the population, and also to make sure that the campaign complements what's going on already in the different communities. There are a lot of great things being done already in local communities, and we want this media campaign to complement the efforts that are going on. We've had some very every name offered brings different skills. The Paso School District enthusiastically accepted to join the superintendent, even volunteered her media public relations team to help with the marketing and the media stuff. So they're excited about participating in this campaign. And I'm very surprised and very pleased by the different responses I received. You probably read by now, the one there at the bottom, one person replied, "I would be honored to be part of this work. Personal pain from the loss of my son due to ACEs and unawareness has fueled my desire to scream the message and help others prevent and heal." So we're putting this together. I believe it's going to be a tremendous success, and I look forward to the next steps, and we'll get into it a little further later on.
Questions? Okay. Thank you, Ruben.
Mark, did you want to talk about?
Thank you.
Our little section, Dennis and I, is pretty small. With this weather, we've, kind of been limited on going out and visiting sites, but that hasn't stopped us. We've been using go-to meetings to attend, to still meet with the providers, with organizations. We've used Skype as well, see our lovely faces, and their lovely faces, which has been great. We've still been able to, ask questions, answer questions for them. We've been going over the reporting workbooks, the toolkits, and then also the budget. If they have questions, the deadline for the budgets was February 15th, which for the most part, almost everybody turned them in, which was really great to see that everybody's on top of things. We're still reviewing the workbooks with some other organizations. Some of them have already to start fill out the workbooks, which is really good to see as well. That means, that they're kind of ahead of the game for reporting purposes. And we'll continue to visit with organizations as many times as, they need us to be there to meet with them. And so far, we haven't got any negative feedback on the reporting workbooks or the toolkits. So everything's been looking great. And, we're happy to still meet with all the organizations that are partnered with Greater Columbia ACH. And, we're happy to visit with every one of you guys. So, that's it.
All right, last but not least, Laura.
So the contract for the Greater Columbia region was awarded to the Behavioral Health Ombuds Service. The Ombuds will assist informally and investigate complaints related to your behavioral health provider. We included the brochure that they had sent us as well as their location. They'll be at the Greater Columbia Behavioral Health Office, and then their address is up there and a phone number if you'd like to reach out to them.
Short and sweet. Anybody else from staff? Are we done, Kelly? Okay. So, usually I'm here in a role of facilitating discussion, but I've been asked this month to get a little bit of content. So that content is going to come from several projects that my shop at Eastern is involved in, called Community Trends or Community Indicators projects. And I've been asked to reference some of the social determinants of health that the LINs have identified. So that's sort of the game plan today. But I hope you recognize that the point of this presentation and exercise is to step back from the outcomes that we're trying to change, if you want to call it the triple aim outcomes. We're trying to move the needle and ask ourselves what factors are really behind our ability to move the needle. So the LINs have identified a few of these social determinants of health, and I think well done. And I'm just going to go through a few of those for the counties that we have. Well, we have actually data on all of these counties, but we have a visualization of the data on about 4 of the counties. These 4 counties do constitute about 90% of the population of Greater Columbia. So what you'll see is sort of the vast majority of, if you will, of our residents in the 9-county area. But my apologies to Kittitas, Whitman, Stoughton, and Garfield, because there are no graphs or there is no visualization for those 4 counties. But I do have some information I've gathered just on my own. So why don't, yeah, we're there. This is a bit of an experiment. Usually I do this running the car myself, and the wheel is now in the capable hands of Lauren, and we'll see how well we coordinate. So by way of background, these community trends have been around in Eastern Washington, starting in Spokane, 12 or 13 years. The most recent is Yakima, the oldest is Spokane, and in between are Walla Walla in terms of their tenure, Walla Walla and the Tri-Cities. And the goal that has been embraced by the communities that we brought these to is really to better inform ourselves about what's going on. And so in this era of, quote, alternative facts, which is a strange sound for somebody like me coming out of economics and social sciences, alternative facts, I'm here to say that there are facts. And we try to present the facts as the best that we know of. And usually the sources are federal sources, census in particular, but lots of other sources that run the gamut from more federal to state sources. So that's the first priority, or the first reason for doing these projects. And the second is that is really related to what we're doing in the Greater Columbia ACH, although broadly speaking, is for these communities to examine what really matters, what the really big priorities are. And it may not be health, although it's always important. And then to see whether through the use of facts, one can move the needle. And we've had some examples of moving the needle, but which I won't have time to tell you about in some of our communities. So those are really the motivators for doing these projects. And I just want to say, a fact is, a piece of information is usually important, but by itself, probably not so helpful. So there's some principles that we've applied to all these projects that I hope you'll see as we go through some of the visualization that make these pieces of information more meaningful. So first of all, we want these to be comprehensive. We don't want to take a particular lens to any project that we've done and say we're going to interpret everything through a health perspective. And sorry for those of you in public health, but you know, there's a world beyond health, and we have, you know, lots of statistics on public safety. We have lots of statistics on economic and business and so on. So comprehensive, not taking a particular lens, and then sort of implicit in that is we're not going to take sides. This is a very neutral sort of activity. In fact, when we first had our Spokane project about 3 years into it, I was giving a presentation to a graduate class at Eastern, and I remember a student saying, well, why don't you have more of a point of view? And we don't want to do that because there's a lot of points of view out there, and we're just trying to present what the facts are, and I think one can use those facts for points of view. Well, as I mentioned, sort of a final principle that we've used in all this is we want to visualize information, and some of this is pretty basic, but they're not tables. You can get very fancy with motion and data visualization, which we don't do in part because we need a lot of data to do that sort of thing. The final principle is probably the most important one, and that is we have had our communities decide the indicators themselves. So Eastern Washington University has not done this, but we've gone and held focus groups throughout the region where we have these projects and say, how do you want to measure yourselves? And so in the end, it's really about the community self-reflecting what they choose over time. The size of the sites vary. Yakima here has about 140 indicators. The Ben Franklin project has about 175 indicators. Spokane has about 200 indicators. Walla Walla, the smallest community, has about 120 indicators. So there's quite a bit of overlap, but in some cases there is difference. We have local funding for these. Some of these came about through a federal grant, and some of these came about through actually philanthropy, creating the site, helping us to create the site. And then since then, there's usually a coalition of funders in each community. In the Tri-Cities, we've got a wonderful coalition of about 10 to 12 funders. So today, I'm just going to introduce you to what I was asked to do on the social determinants of health. SDOH is what came across on my email. But I have to say, Ruben, I've amended that to read it ESDOH. I'm an economist, and that E stands for economics. And we're gonna consider a couple economic indicators, and not to say that economics is the primary source of everything, but if you don't have income happening in your community, income growing, it's hard to do a lot of things. So we're gonna start out, if you don't mind, Lauren, by looking at under economic vitality, and then looking at under income, and then we'll click on median household income. Okay, so we're gonna see this in the other communities as well. So what's the motivation here? Well, I like to say that health follows wealth. Health follows wealth. And if we don't recognize that, I think we're deluding ourselves. And what does wealth follow? Wealth usually follows income. It's our ability to save and create wealth that really helps determine outcomes. And if you were to overlay a map of any of your communities on the variability of health outcomes, say the classic one, just lifespan. Overlay that lifespan mapping with income mapping. I bet you'll have close to 100% correlation, or pretty darn close to 100% correlation. So I think those of us involved in healthcare reform, if we don't consider what's going on the economic sphere, it's to our peril. So this measure, this is for Yakima, gives you a sense of how we do these projects. We have a time trend, because we always try to provide context over time, and we provide a comparison to other communities, in this case, the U.S. and the state of Washington. So in this case, Yakima is the red line. You can see that's moved over time. Black line is the U.S. median, and green is the state of Washington. So just a quick word about what we're measuring. We're measuring households, not per capita, and we're measuring medians and not averages. And there's a big difference when we look at certain indicators in economics between something that tries to measure the central part of a distribution of numbers. And the median is just that number in the middle of the line that divides the upper half from the lower half, whereas the average takes into account the values. So if you've got several Bill Gates in your community, I'll tell you, the median is quite a bit different than the average, okay? Because of the values that person brings to the measure. So, looking just at the specifics of Yakima. Oh, by the way, for those of you in Yakima, I just want to point out this. We have an overall view, and then if you go up to the radio buttons, and I'm not going to show this to you, but we have the city of Yakima, then we have what we call the Upper Valley, we have the Mid Valley and Lower Valley. So we could get even more detailed, but it gets very complicated with the graphs. So we combined some of the communities, as you can imagine, in the Lower Valley, Sunnyside, Grandview, into one measure. The data, if you were to click on the download data, you could find all the data for every little unit that we're using if you wanted that kind of detail. And then finally, if you clicked on more information up there, you could find out what median household income really is if you forgot what I just said. So gives in about three to four paragraphs. So let's look at what these economic determinant of health is saying. So if you want to click over or mouse over the last button in 2017, right here, there you go for Yakima. There you go. So 47,400. You can see that's lower than the U.S. In fact, that's about 79% of the U.S. So that's quite a gap income-wise between the U.S. and Yakima, the 300,000 plus souls who take residence in that county. And if there's a big gap between Yakima County and the state of Washington, why don't you mouse up to the green line, 71,000. So 47,000 versus 71,000. Big difference. That probably has something to do, I mean, that probably has some effect, do you not think, on what some of the health outcomes are. Okay, so let's go to Benton Franklin and see the same thing. So remember the positions of those metrics, and we'll go to economic vitality, we'll go to income, and the second one down is median household income. Okay, why don't you bring it up here. Now, in this case, the blue line is the Tri-Cities. Look at this. The blue line is above the United States and pretty darn close and sometimes equal to the state of Washington. And if you mouse over the 2017 value for median household income in the Tri-Cities, the number is almost $64,000. So you're going from Yakima, 47,000 to the Tri-Cities, $63,000 to $64,000. Does this have an impact on health outcomes?
Yeah.
I would say it does. So this is unusual in Eastern Washington, however. Most communities in Eastern Washington do not enjoy this particular tailwind that the Tri-Cities do. It's gone up over time. That change is statistically significant. And by the way, the Yakima increase over time was also statistically significant. For those of you in Yakima, I forgot to say that you have increased over time at a pretty nice rate. The starting value for incomes in Yakima has been really, really low. So let's go to Walla Walla. And Martha, I hope you're still on the line because this particular indicator includes Columbia County. You may not know this, but the combined populations of Columbia County and Walla Walla County make it the 382nd largest metro area in the country out of 385. But you are a metro area because of the commute pattern going back and forth between probably Dayton and Walla Walla. So we don't have as long a time frame here because this is one of the youngest MSAs in the entire country. But you can see here that the red line or the burgundy line we like to think of for the two counties is below the U.S. line in contrast to what you saw for the Tri-Cities. And it has gone up over time, though, and the gap is not nearly as large as it is in Yakima. So that number is 54,000. If you want to mouse over that, 54,000, which is about 90% of the U.S. median. So there you have it for like I said, 90% roughly of the population. What does it mean for the smaller counties? This measure, didn't take the time to try to visualize this, but for those of you from Asotin County, 47,000. For those of you from Garfield County, 51,000. And for those of you from Kittitas County, 53,000. All below the U.S. median. Okay? So that's the lay of the land here. Every community in Eastern Washington that's a part of the GCACH is below the U.S. median, except for the Tri-Cities. Okay? Now we'll go to poverty, because poverty is one measure of looking at the distribution. What we saw right now is just a look at some attempt to give a middle value and to try to summarize in one number what things look like in income. But poverty looks at what's happening to the bottom decile, quartile, however big that is. And I don't think I need to motivate this very much, but I think we all know that this poverty threshold is used a lot to decide who qualifies and who doesn't qualify for Medicaid, right? With the ACA, that's now 38% of the poverty level. And the poverty level doesn't vary by geography, but the poverty level varies by size of family and goes up every year depending on inflation. And there's a whole history of poverty, of the derivation of the use of the poverty measure, which I won't take the time to do right now. But just know that a lot of people think the poverty measure is inadequate to measuring the lives of those at the lower end of the income spectrum. And so I don't think there's anybody here from United Way, but the United Way has come up with another measure called the ALICE measure. I don't know if people have heard of ALICE, asset limited, income constrained, something. And much different numbers in terms of what is a poverty threshold. So let's look at Yakima. If we could, poverty is under equity and inclusion, and click on that one subcategory, Lauren, and we'll look at, where is that? There you go. Yeah, this is all age poverty. You can get poverty for kids, you can get poverty for seniors, you can get poverty for all ages. So we're just looking at the all age poverty rate. Again, this is Yakima County as a whole. The red line is Yakima, and the benchmarks are black for the U.S. and green for the state of Washington. And you can see what Yakima is facing in terms of its poverty rate. Why don't you mouse over that? 18% versus the U.S. of 13%. That's a lot of people. So if you just come down a little further below the numbers, no, and just on the bar. So, close to 45,000 people are living at the federally defined or below the poverty level in Yakima County. And just by way of information, the federal poverty threshold for a family of 4 in 2017 was about $25,000. So anybody with income at $26,000 or $27,000 for a family of 4 was not poor by this measure. So you can see some of the inadequacy of trying to measure just the economic pain that people find themselves in. Now the good thing here is you might be able to detect, if you were to draw a line, is that the poverty rate has come down over time. It was 160% of the U.S. average, and now it's 135%. But lower here is better, right? Lower is better. So. Okay, let's go on to Benton Franklin. So remember that 18% Yakima. Let's go on to Benton Franklin, and Benton Franklin is going to be an economic vitality at the bottom under poverty. And there you go. So here we are for the two counties, and you can see it's quite a bit different already. No elevated line above the green line or the black line. In fact, it's in between by and large right now. Probably statistically not too different. And if you mouse over that, Lauren, I don't know if you can, but the rate was actually a little less than 13% for the two counties. Susan?
Just do a real quick thing and go over to Franklin County, select out.
Okay, so real quickly, when I started working down here, I said to the steering committee, I said, what should we cover? How, should we just do the MSA, the two counties together? Oh, you can't do that. You got to do two counties. So we did Benton County and Franklin County. And I said, okay, are we good? And they said, no, this is the Tri-Cities. You got to do all cities. You got to do all 3 cities. So we have, for those of you from the Tri-Cities, we have different layers here. So which layer are you trying to look at, Susan?
I'd like to look at Franklin County.
Okay, Franklin County. So just remember, well, you can see it. Franklin County has been elevated, as probably no surprise to anybody who lives here, but it's come down. And the most recent estimate we have is, census has, is not too different from the overall rate. And I think those of you who live in Pasco know perhaps what's going on. There's a lot of people going across the bridges. So this measures where people live, not where they work. Okay, on to Walla Walla. So Yakima 18, 2 counties 13%. And here's Walla Walla and Columbia. Look at this. Below the benchmarks in contrast to what we saw for the other communities. So, well, not quite. Close to the state of Washington. So that rate is 11.6%. And that's been decreasing, as you can see, over time. And the nice thing about census data, you can actually construct significance tests and say, is that a meaningful drop? And it is, in this case. It's a meaningful drop over time in the 4 or 5 years. So what about the other counties? What about our small counties? Stoughton County, 13 for 2017, 13.5%. Garfield County, 11%. And the real surprise to me was Kittitas, 20%. Kittitas has a poverty rate as registered by census as 20% of the people. And I've been thinking about this, and I'm thinking, this probably has something to do with the fact you got students living off campus. Because in a lot of college communities that have off-campus living, the students are counted as part of that community and not part of their parents' community. If they're on campus, they're not counted. So this could be a little bit misleading for Kittitas, what's going on. Okay, I'll just take time for 2 more indicators. And why don't we go to, let's see where we want to go to. Let's go to Yakima again. And we're going to look at food insecurity because this came out as one of the issues. And this should be, look under health. Let me see, under vital statistics. You should know where this is. No. Look under economic vitality. Darn it, I should have done this. That's not it. Look under equity and inclusion one more time. There it is. Okay. So this is a very difficult thing to measure. And in fact, I didn't think this was available to be tabulated in any sort of way. But this has been an effort by the food banks across the country to come up with some measure of the distress that people find themselves in with regard to nutrition. So there's a umbrella group across the country called Feeding America that produces these data that we use. And it's a little complicated. It's not a direct survey. It's sort of, they use a bit of black box economics, which I still quite haven't figured out. And the other thing you should know is that these are 5-year rolling averages. Okay, so it's not year to year. And here's how they define food insecurity. I don't know what the LINs have come up with, but here's how Feeding America says it's eating diminished amounts of food at any particular meal or skipping complete meals due to the lack of financial resources to provide proper amounts of food 3 times a day. So that's their definition. And you might see here there's 2 sets of lines. One is for children and one is for all ages. And I'll say this, children's rates are always above all age rates. Our children are doing much worse than seniors. They're doing that in poverty and they're doing that in food insecurity. For those of you who are in communities where you have weekend backpack provisioning, I think you may know what's going on there. But a lot of our kids don't have enough to eat. And I was just looking at the EWU bulletin board the other day, or the announcements, and we have a forum this week on food insecurity for Eastern Washington University students. So it affects lots of different levels of young people. So here we are in Yakima. Surprisingly, the all-age population rate, for me anyway, since we saw the poverty rate, is below the benchmark. So if you want to mouse over that, for the most recent years, and of course these come with a long lag, it's a little less than 10%. But then if you look at the dotted line here, you'll see it's 22% for kids. So if those of you in the LINTs are looking at intervention areas, I think you've got a little head start here on where you could make a dent. It's, again, there's obviously issues with everybody, but in particular kids. Okay, so that was Yakima. Let's look at Benton Franklin, and I think this is under health in Benton Franklin, I hope. Look at vital statistics. There it is at the bottom. So same set of lines, and you'll see that for kids, elevated here, better than the benchmarks. However, surprisingly to me, the all-age result wasn't as good as I thought it was going to be, but it's not bad. If you want to come down to the blue line, 9.8%, so below the benchmarks, 9.8%. And we haven't done any calculations here, but there's been a slight decline if you were to trace that out. And then for Walla Walla, that should be in the same place under poverty. Is it, or maybe it's under health. Try health. Vital statistics. Let's see if that's there. Okay. Well, let's not spend our time because I need to wrap up here. So Walla Walla is a little higher, surprisingly, at 12%. So just the big metro areas, 9.5%, 9.8%, so roughly identical between Yakima and Benton Franklin. Walla Walla close to 12%. But what about the small counties? Okay.
What about for kids for Walla Walla?
Pardon me?
Kids for Walla Walla.
We didn't do it for kids. Well, we did. I'll find it for you, Carol, and send it to you. Southern County, close to 14%, 21% for kids. Okay. Columbia County, the same, 14%, 21% for kids. Garfield County, close to the same, 13% and 20% for kids. And Kittitas County, a little lower, 12.4% and 19% for kids. So got some elevated rates there for stress in nutrition. And I think I'm going to stop, and what I'm going to suggest, Wes, is perhaps over the next few meetings, I can just do one at a time, just do one social determinant of health for like 5 minutes, because I want to respect our agenda going forward. But I've got, because this came up, Ruben, I've got looks at housing, health insurance, and a bunch of things that are all on these sites that we can do, and I'll show them to you. And of course, those of you who have picked up the brochures, you can look at these yourselves. Those of you involved in the LINTs can do this yourself. We think this is pretty user friendly. We try to design these sites so you get to what you're looking for in 3 clicks. And I hope you've gotten a sense of how to navigate these over time. So I'll just leave it at that for the time being, and just say that again, these are not numbers; these are people. And there's a story behind all these trends. It's not just numbers. And sort of one of our goals is to help people sort of understand what the story is. And we don't have all the answers, but we have some clues to some of the answers. And so be happy to help, and hopefully we can carry on this conversation going forward. So any quick questions before we move on? Yes, John.
So you've looked at 3 different places, Benton Franklin, Walla Walla, and Yakima Valley.
Yeah.
Why did you choose those 3?
Because they're combination of factors, because they're large. So you're dealing with a lot, the impacts are going to be meaningful. And second of all, there was funding available for the counties. These are not free. It takes a lot of time to develop this, and even with students who don't earn as much as we do, it costs money. So we have them in some small counties like Pend County, Stevens County, Grant County, but we had hoped to do it in Southeast Washington, but we couldn't find the funding to do it in Southeast Washington. And I've had conversations with folks in Ellensburg a few years ago to do it for Kittitas, but that didn't materialize. So who knows whether we're still rolling these out, so it's not to say we can't do them.
All right, thank you.
Okay. Well, we're going to switch gears then, and I hate to be in front of you this long. I'm typically a facilitator, not your presenter, but I'm going to be your interpreter now. And we're going to look at something that came back to staff about 6 weeks ago from the Center for Community Health and Evaluation. And for those of you who have been with us long enough, you may remember one of these people sitting in the back of the room taking notes. So we were being observed over time by this group that's been engaged by the health authority to make sure that we're doing what we're asked to do. So this is an annual evaluation. This is, I think, the first time you've seen this, right? I don't remember presenting this in 2017, the results for 2017. These are the results that many of you probably filled out based on surveys, questionnaires that you filled out for 2018. So we're going to run through these relatively quickly and then ask for some comments. So you can see what the goal here is. It's not a report card, but it's part of the continuous learning process that many organizations that we work in are engaged in, just trying to get feedback so that we can do a better job going forward. And we'll go into this last bullet about the size of the N. And we're going to talk about this at the end too. So what surprises you about what you're going to see? What is working, what is not working? How do we build on our strengths? How do we address our challenges? And then sort of an open-ended question, what do we want to be going forward? So who responded? Next slide. You can see that on the left-hand side, we had 105 people respond to the survey, which was quite a bit higher as a rate than the state average. So congratulations to everyone. Pat ourselves on the back that we care enough to fill out a survey. And then this is the board response on the right, obviously a smaller population, but our board has been more engaged than boards across the state of Washington as well. So not a bad thing. You can see, just go back one more time, the survey was sent out to only 163 people in 2018. And I don't know why it was 163 versus 400.
Well, so in 2017, I think we were in the throes of doing the letters of interest, and we were really jammed. And so we made the decision at the staff level just to send it out to our distribution list. We realized after we got the results that was a mistake, because so many of the people that we sent the survey to had not been involved in our ACH at all. So this year in 2018, we took a much more targeted approach, and we selected certain groups like the Practice Transformation Work Group, the committee members, the Leadership Council, and the Board of Directors. And so rather than just doing a mass emailing, we had a much more targeted list. And I think that the results reflect that too.
So a better informed result. Okay. So here's who responded in general terms. You can see the provider organizations, including the behavioral health organizations, was the largest group, no surprise. The Practice Transformation Group, which was a mix. The Leadership Council, which is you. The governing board, we had 15 out of the 17 or 18 that are on the board, and then people in the LINs. And there's a note here that there's some overlapping membership. So if you were to add up the numbers involved, it's certainly more than 105. So hopefully more than 27 of you in the room responded, which I imagine happened. Okay, next. Okay, so that's kind of a little more of a drill down into who responded: behavioral health number 1, primary care number 2, CBOs number 3, hospitals, and then public health organizations. All right. So this is, I think, a significant piece of information because it shows just the degree to which people have been involved over time. And I'll just put in my 2 bits worth here. I think you get a better sense of how to evaluate anything if you've been involved for a period of time. And you can see that for Greater Columbia, we have the state is the top line, Greater Columbia in 2018 is the middle line, and you can see that we've got about the same number of people involved between 2+ years as the state does. So if you just add those together, that's about 40%, and if you add the state, it's about 39%. So you're going to see this as a theme, as a motif throughout these slides, is that as much as we'd like to be like Wobegon residents, we're not always above average. So we're about average here. Next. And this is response then to the level of engagement. And you can see here, if you add very engaged plus the engage, that we're looking at about 2/3, and you're looking at that's a little bit more than the counterparts statewide. So here we are a little bit like Lake Wobegon. We're all above average on engagement. Next slide. Okay, so this gets into some of the nitty-gritty on what we can do differently. This is the general question: are the levels of satisfaction that you have with the ACH? And again, we're in the middle, and you can see that generally about 4 percentage points above the state, and we're pretty close to three-quarters of the respondents saying satisfied or very satisfied. 3/4. Next. Okay, these are the 6 domains. I'm not going to spend the time to go through this. This will be online.
Yes. Yeah.
You can look at the bullet points at your leisure, but you can see it's participation, governance, community engagement, a statement of mission and goals, basically the functioning or the operations of the ACH, and then the projects. So those 6, and with a standard GPA sort of rating scale of 4 to 0, 4 being best. Okay, here we go. We are in the dark. The state is in the light, and you can see at the very top is all 6 domains, 2.8 versus 2.8, so average. Projects, slightly different, slightly higher. Organizational function, slightly lower. Governance, the same. The statement of mission and goals, slightly higher. Membership engagement, the same. Community engagement, the same. Okay, next.
So I was just saying, if you guys have a question on what do these domains mean again, we can always go back and read what that domain description is about. So that's why we included that slide in this presentation.
So this warms my heart because I'm an economist, I'm a trends guy, right? So we have 2 observations here, 17 and 18. The most recent one being the darker one, and you can see that in all cases we're improving. So I thought that was pretty significant in terms of how folks were rated. The biggest improvement came in community engagement, which was the lowest ranked in 2017. Okay. Okay. I'm not going to spend much time on this because I think I've already sort of given you my interpretation, and I don't think there's a whole lot more to add. Why don't we go further? Okay, so let's spend a little bit of time on this. So strengths, the top 3. leadership and staff, with close to 40% rating outstanding. Somewhat similar, the leaders, basically, that includes you who are participating on the board and in the leadership council as outstanding, and then communication, with 35% rated as outstanding. Okay, so a little SWOT analysis here. Where we could do better, and opportunities, engaging the broader public. A quarter of the respondents said we can do a better job here. And this is related then communicating effectively with the broader community. A little less than a quarter said we could do a better job. And then I think the conundrum that's facing every ACH, I'd be interested to see what this looks like for the Spokane ACH, which I know of it. And how we proceed beyond 2021. In other words, what happens in 2022? We really haven't had that discussion, so it's hard to say that we made a lot of progress there. I think the staff feels like still they've been drinking through a fire hose, and so it's hard when you're drinking through a fire hose. It's hard to think about how you're going to irrigate your plot in 2 years. Okay, let's go a little further. This is a pretty detailed look at the different components of what you just saw in the 6 domains. And I'm not going to take the time to show you other than to say that by and large, the 105 folks who evaluated this gave pretty good marks to all these different measures, except for 2. And if you'd click on those 2, I think just one more click of the mouse will get us there. No? It should be highlighted. I guess it doesn't do that. Okay, so we'll just respond then to the bottom 2. My ACH is helping to align resources and activities across the region. Okay, so plain coordinator / it's a traffic cop about how some of these organizations and resources that go to the organization who are working in the same area might work together. And then the bottom one, where we have the lowest score, is my ACH is helping to reduce duplication of efforts by forming linkages between organizations. Okay, so people recognize that we have duplication of efforts here still, and we're not there yet.
So these are really important points that the state of Washington calls out on us to report on in our semi-annual reports, not only within our regions, but also across the different ACH regions and really across the state of Washington. So these last 2 items, the alignment and the reduction of duplication of services, are areas that you can really help inform us.
Okay, we're gonna have an opportunity here shortly, very shortly, to comment. I hope you'll have some thoughts on this as we go forward. Okay. There you have sort of the same look except over time, and even looking at the bottom 2. Where we probably need work, aligning resources and reducing duplication of efforts, you can see that according to those people who responded, we've made progress over the last year. So probably a bit of I wouldn't say uphill effort, but a bit of an effort, and I'm happy to see that there's some improvement. Okay. Don't think we need to do this. This is just looking at the board. We'll leave this for the board to look at, Lauren. Okay, so now this was some open-ended boxes for comments. Some of you may have supplied, and we're just going to take a couple of these. So the first one is engaging partners across regions, organizations, and things like this. So one comment was, as a success, growth with the inherent inclusion of behavioral health and substance abuse disorder services in particular. That's one comment. Number two, building partnerships with multiple agencies across the region. So somebody thought the ACH was doing okay there. Now about the projects, especially bidirectional integration. That's kind of long for me to read, so I won't read that. But the CSAs, the community status assessments, were called out for their good work. The added staff that Carol has brought on was recognized and gotten a nod too. Okay, next slide. Okay, what could the ACH do better comment-wise? You see the first one, and I haven't had a chance to ask Carol. Maybe I'll put you on the spot, Carol, and see if you have a response to this. At times, there's been some very nice timeline reviews. Keep those up. Didn't get one for the timeline and practice transformation. So what about timelines? Is that something the staff has thought about to provide regular timelines about where we're going?
We actually do that with the board of directors, but we can start including some of those timelines in our GCACH report, if that's what you guys want to do.
Okay. And then for people who come, I remember a few people who have brought this up before here, I think, John, you were one of them, is for new members, if we think the staff is drinking at a fire hose or through the fire hose, anybody who comes right now is probably in the same position. There's a lot to learn. And for those of us who have been at it a while, it's a little easier, even though it's still pretty overwhelming sometimes. So I think that's pretty clear that that's an issue. And I don't know, have you thought about what could be done there, Carol?
Yeah, so again, unfortunately, a lot of the time we do on onboarding is with our board of directors. But I do agree that we need to have more of a, packet for leadership council members to, come to our meetings too. So really would love to have your feedback on what you think that should involve, because the board gets an extensive overview and an onboarding process when they come on.
Okay, and then just on organizational or operational issues, it could be less bureaucratic, but I think this is more part of the state system than our ECH. I kind of laughed about that because I deal in a bureaucracy called the university, and it's hard for me to imagine 7 or 8 people involved in ECH being bureaucratic. But somebody thought that, so need to take that into account. And I think this is more of a board issue than the leadership council, because the board actually makes decisions with dollar signs attached, and the ACH, according to this commentor, is proceeding on the basis of consensus, full consensus, whereas sometimes maybe it could go faster if there were just a majority vote, what this person is saying. So I don't know if you have comments to any of those, Carol?
Yeah, I don't know, I think it's up to the board, and I don't know what happened to Dan. I guess he had to go out.
No, I'm.
Oh, there you go.
I'm kind of pressed for time.
Yeah, I mean, I don't know if you want to respond to that, because I think that there have been dissenting votes at the board level, but if we can achieve consensus, we do that. We send a lot of things to our committees now, which takes a little bit more time. That's part of that bureaucracy. I think that's happening, but I don't know if you had anything about consensus decision-making.
I think we spend a lot of time at board meetings developing and having good divergent discussions and work towards consensus. Not everything is a rubber stamp, that's for sure. We work it through.
Wes, comments?
Yeah, I just think that there's a lot of time spent helping everybody get a thorough understanding of what's going on. I think that the importance of each member understanding so that they can make a decision takes time, if I haven't been around, especially if I miss one board meeting, it takes me a lot more effort and time to get my brain back around things. If I can come to this meeting before, I'm pretty much ready to go. So it depends on how much, me as an individual can participate to how ready I am. So I think there's a lot of, I think there's an effort to make sure each person is well informed and has an understanding before, and then again, we don't always agree, and that's good.
And then Ronnie is here.
Oh, Ron, quick comment, we're gonna have to shove on because we're running close to my hour here.
Spending time on the board and what I understand, sometimes I'm in this deficit, and so I have to ask those questions, why are we doing this? And what's that end game look like for the people, the consumers that are going to be on the receiving end of everything that we do? So if I don't understand it, I can't take it to the consumer and say, you know, just rubber stamp it, because we can't. We have such a responsibility to our consumers and to the people that service those consumers. And so being able to be on that board and understand completely what our significance is to the receiver of this is really important. And I think that when people are in this conversation about what's happening, why it's happening, and we have an understanding and there's disagreements on the board, we really do vet things really well, I think, because of the diversity that's on that board.
Yeah. Well said. Okay, let's move on. So challenges for this upcoming year, bringing all the stakeholders into agreement on service priorities, tightening communication with different providers. Okay, so yes, I think we can agree to that, right? Coordinating with the BHOs into a consolidated provider network. That would, I'm sure, somebody here can attest to that. Diane, I don't know if you want to comment. Implementing the Medicaid transformation projects. The support in the transition without decimating the providers. And I'm not quite sure what that means, the MCO transition. I don't know if you all have a clue there, what that means. And then I think this is no surprise to anybody, is that last line, some agencies are going to be struggling to bring integrated management into their shop, and the ACH might find those agencies not having the time to spend on the project. So, quick comments, Diane? This is more in your domain. You agree? You disagree?
I think that we did pretty good getting ready for it.
Why don't you turn around and speak?
But I know that there's people still having some issues, and that will get brought up. That's why we're continuing to have meetings for them twice a month. So hopefully their issues will get addressed.
Okay. You've seen this before, so you know, right? Okay, so what difference has the ACH made? I think you can read that for yourselves, but I hope generally you might agree with those. There is a value of connecting the different geographies of these 9 counties and learning from each other. And so I thought that was helpful. So again, going back to some sort of summary statements or summary visualization of what the Healthcare Authority wanted to look at. The bottom line is the overall score for the 6 different domains, and we're the dark circle there, and you can see that we're just about average. 3 below, 2 above, 2 equal to us in the point score. So, and you can see that there's some variation among all the ACHs, and you can, I hope, see very quickly that community engagement is probably the most challenging domain to score well in, and maybe that will be the subject of some thoughts that you might have about how community engagement can be improved in our particular ACH. Next slide. Okay, so here we're going to just ask you very quickly to phone in, to text in some of your thoughts. What surprises you? Where are we here? Okay. So we're going to ask you if you feel so inclined to go to menti.com. And we're going to do this in real time to see how this works. Just give it about 5 or 10 minutes and see if we can get a conversation going. And then you see the access code up there. So 211819. 211819 menti.com. menti.com. Okay, number one, how can we effectively communicate with the community? So this gets back to that last slide, essentially, where we and all the other ACHs seem to score the worst, is on better communication outside those of us in the room here. So if you have any thoughts on that, please type them in, and we'll just wait a couple of minutes and see what pops up. Yeah. More parties.
Okay.
Hey, plotting.
Wow. Thank you. Those are some good thoughts. All right. Well, these will be obviously recorded by our team here, and at the next video, let's talk about these. Let's go to the next question. Well, yeah, let's go to the next question. Okay, this is the Linkies question. This is trying to have better playing in the sandbox, so to speak. How does that happen? I'll just say from my work in largely Spokane, this is always a big challenge. How do we work with organizations that have been doing the same thing, perhaps in parallel with other organizations, perhaps in the same community, to work together? Yeah, I'll be interested to see what you all come up with. Some good thoughts so far. Thank you for that feedback. And then one more question, and then we're gonna change the agenda a little bit to accommodate Dan and Kirk. How do we align resources across organizations and activities? So I think align resources is code for how do we spend money, right? I mean, I don't know. Does anybody want to interpret this question for me differently? Pardon me?
I think this also points back to the comment about duplication of efforts. Alignment includes that as well, forming collaborations and partnerships to help do things a little bit more efficiently.
This is somewhat the same question as the second one. Okay, good. We have some thoughts on this one as well. Very good. Okay, you can keep on texting if you like, but in the interest of time, we need to accommodate a couple of our LIN leaders who need to leave the meeting early. So I'm going to have Ruben take it from here and introduce these folks, and we'll have a report out, hopefully time for some discussion.
Yeah, so this is a slight change to the schedule in terms of the order of events on there.
Kirk, Dan, you have to be somewhere at 11, right? And Kirk, you have to leave at 11? Okay, so why did you go first, Dan? Oh, that's right. I did an introduction. So we're going to have three LIN, Local Health Improvement Network leaders, go over the process of selecting their social determinant of health priorities within their regions. Each Local Health Improvement Network got some funding to address those social determinants. So each of them, Dan is going to speak for the Yakima County Healthcare Coalition and their process of how they arrived at their priorities.
All right, my apologies. I'm actually meeting with a gentleman from Pendleton and talking about the opioid epidemic and workforce issues at 11 o'clock in between this meeting and our board meeting, so my apologies. So I've been involved with the Yakima County Healthcare Coalition for about 2 years now, and you can go on to the next slide. Whoa. This is the kind of the group of organizations that make up that, the Healthcare Coalition. And I'll go ahead and just describe very briefly what we did in terms of responding to the request for the understanding the social determinant of health needs in our community. Go ahead. So
I like that.
I'm not sure who did that. Rhonda Huff, who is the other co-chair of the Yakima County Healthcare Coalition, was a big resource in helping to kind of formulate some of the ideas. In conjunction with good discussion at our coalition meetings, we decided to use the Prepare tool. We converted paper surveys to SurveyMonkey and distributed electronically to various agencies to focus on our outreach efforts during the summer. We collected over 500 surveys in 6 weeks at farmers markets, parent nights, and back-to-school events, etc. So I thought we did a pretty outstanding job of getting out there. We had a lot of volunteers with amongst those agencies, and and I'm sure that I know the staff helped a lot. So this was, I think the next slide is a copy of that prepare tool. What it does is evaluate measures, SDOH, not ESDOH. Anyways, but I totally agree, by the way, on the economics pieces of that. Okay, the next slide. So our top results from those surveys included housing, education, employment, transportation, and emotional and mental health. We thought it was pretty interesting, kind of that blend of education and employment. Where do jobs fit in? So I think those are things that we still need to kind of tease out. But our focus is really going to be on housing, education, and employment. Transportation, I think, is also a big issue. And of course, you can't leave out emotional and mental health. Go ahead and go on to the next. So our priorities actually align very closely with what the United Way and the Yakima Community Foundation have been focused on. We've actually asked the Yakima County Foundation to be the third-party administrator. RFPs went out early January to a variety of organizations, and we should be hearing soon about the results of those RFPs. Any questions? Appreciate the adjustment of time.
Thank you, Dan. My understanding is the Yakima County Community Foundation received over 23 applications for their RFPs, and they indicated that's pretty unusually high. So that's wonderful news. So now we have Kurt Williamson for the Benton County Benton Franklin Community Health Alliance.
Thanks, Ruben. I don't have as good an excuse as Dan. I missed a meeting and got elected president of another organization that meets today. No good deed goes unpunished. So we went at it a little bit differently, but basically we looked at some different sources of information. The most significant one was the one done by Tri-Cities Community Health. They stepped up and did almost 700 surveys in the course of less than a month. And you can see the results that we had there. This is a display that we showed to our last Alliance meeting. We asked Alliance members by SurveyMonkey. We did some public surveys. We also published a survey online. And then we kind of balanced that with what we could learn from 211. The note there is that 211 is not not specific to Medicaid, and the others are specific to Medicaid. Next slide. So we asked our members after we showed them the survey information, got them all in a room, about 40 people, and said, okay, what in this list of priorities of these things, help us sort this out for the top 2 or 3. And these were the ones we showed them because they showed at the top of almost every survey instrument we did, every place we asked the questions. So this is what we came up with: housing, mental health, and food insecurity. And we're concerned about transportation. One of the things that's happened in Benton and Franklin counties is that Benton Franklin Transit discontinued a night taxi feeder service last October, which had been serving quite a number of people who would normally have been included in a survey, and transportation would have been a big issue. So it sort of moved up, but it didn't become in the top priority. So those are the 3 priorities that we have, and you can see that they track along with, probably in pretty closely with the other lens. Okay, last. We're going to do one more step here. We have about 200 plus individuals and organizations on our email list. So we're going to ask them to drill down just a little bit more. They selected the broad category of housing, for example. So we're going to ask them a little bit more about what they really think and what they think we ought to be doing with regard to housing. we'll do the same thing with mental health and the same thing with food insecurity, and see if we can just get a little more information. Our next meeting is March 19th. We will have the survey out and back by then, and we'll kind of value that. We put some value both on what we can gain from people giving us direct information from their own point of view in the surveys, for instance, the Tri-City Community Health did. But we also put some value in what the people who are members of the Alliance, who deal with those folks day to day and their needs and issues. We want to use those two sources of information to balance each other. Question? Great, thank you.
Kirk, maybe you might tell the group how you're going to proceed then with the RFP response.
Oh, okay. We are waiting. We have selected our third-party administrator, is Three Rivers Community Foundation. We're on the information that we will provide to them based on this final look at the surveys will help inform their RFP process. So we're a little bit behind Yakima, but we expect by April 1st to have that information in the hands of our third-party administrator, and they'll be looking to put out some RFPs.
So we got a question from Ravine, so I can answer Ravine's question.
Oh, good.
So Ravine asked the question, what is the difference between supportive housing and rental assistance? So Barbara Mead can answer this, but my understanding is supportive housing provides services on site for those people who need special services, people that are chronically or mentally ill or have some kind of a disability. Supportive housing would have somebody on site to help them navigate the everyday daily living activities, right? Okay, all right, thank you.
Thanks, Carrie.
Any other questions for Kirk? All right, then we have Kittitas County coming up, right?
Yes, Dr. Mark.
Dr. Kevin.
So I'm filling in for Robin Reed this morning. I want to talk a little bit about where KCHN started. In 2017, we came together, and our principal thrust was supporting county health, which at the time was run by Robin Reed, in developing community health assessment, community health improvement plan, and that became the strategic plan of the network. And as part of that work, we had done a lot of the similar to what you've heard, going to farmers markets, surveying patients in clinics, going to community events. So we had a pretty good sense of what the overall community's concerns were. What we didn't have was specifically a sense of what the Medicaid beneficiaries' concerns were. So what we did was, we borrowed a tool created by CHCW. CHCW and KVH are the only providers who touch the Medicaid population in our county. We borrowed the tool from them in the interest of time. It was given to patients, principally at KVH, also at CHCW, and also addressed some in the general public. The instrument they use is based on the AAFP, American Academy of Family Physicians screener for social determinants, which addresses housing, food insecurity, income insecurity, and safety in the home. We got 134 responses, which in a county of 45,000 with probably about 5,000 Medicaid beneficiaries, I thought was a pretty reasonable response rate. This wasn't really a surprise to us in terms of what we already knew about the county, but what it did do is, if you look at this slide, almost all of these responses are directly related to safe housing or safety in the home. 14% of our 134 were homeless. Another third essentially were worried about becoming homeless. That's a huge number right there. Food insecurity was significant. 22% worried about running out of food before the next paycheck, and 14% that didn't have enough food for the week. We do send backpacks home with school kids on Fridays. Because if we don't, we know that those kids probably aren't going to eat before Monday. 44% having trouble paying power, water, or heat bills. To us, that's also secure and safe housing. When I left Ellensburg this morning, it was 18 degrees, and if you don't have heat, you don't have a home. The other one that needs to be called out is that 7% did not feel safe in their home, whether that's domestic violence, whether that's simply that you don't have a door that locks. So, in December, our Leadership Council, we have an organization similar to this body on a smaller scale. But our Leadership Council went through that data, went through the GCACH. There are other issues that we had already identified, but they are specifically healthcare issues, mental health care coordination. The IT project that we're working on with GCACH is part of that care coordination limb. But we really hadn't set priorities around social determinants, and this kind of pushed us to that. And housing and food, not surprisingly, are the big ones where we felt we could get the most return on investment. One unique, and this is actually to Patrick's point, one of the things that's driving housing insecurity in our county is the university. Because what's happening is the university doesn't have adequate student housing. So a lot of kids are displaced off campus, and they don't really care how much rent they pay. They go to the bank of mom and dad and make a withdrawal. And mom and dad don't know that what it takes to get affordable housing in Ellensburg. So if I've got a 3-bedroom house and I can put 3 students in it and charge them each $800 a month, a family of 4 might have trouble matching that $2,500, $2,800 rent. So that really is, we're at the point that when we look at our median income for a full-time job in the county and the median housing unit, you have to have about 2.5 full-time jobs at median employment to afford the median home. So we need housing. And quite frankly, I think we overthink it a little bit. I think what we really need to do is get out some shovels and hammers and build it. But maybe that's what some of the RFPs will come in for. We have also asked Yakima Community Foundation to be our third-party administrator, and we are in the process of generating the RFPs. We hope to have them out for this cycle, and we'll see where we go. Questions? Yes.
With respect to HUD and the ability to build affordable housing, what's the position of your housing authority?
The question is, what is the position of HUD and the housing authority in the county? A lot of our community action agency is HopeSource, and they wind up doing most of that work. They're also a partner in the network. And in fact, we're originally, we were housed at HopeSource rather than at county public health. That decision was made because when we thought we were going to be staffing up, we now have staff. Robin Reed has left the health department and is now our executive director. When we were going through the planning process, we thought that if we had to do our hiring through the county and all of the posting and interviewing requirements that they had, we thought we were more nimble if we were administered through HopeSource. HopeSource has been trying to build units in the county for years. I'm sure that none of the rest of you have people in your counties who think the solution to any problem is great as long as it's not in their backyard. So most of the places that HopeSource has been able to identify as candidates have been struggles. We are building housing. The university, importantly, is building several hundred units currently. They're short about 2,000 units of being able to house all their students on campus. And so that, I think, it may be that the university actually winds up being the solution to a lot of the housing, and just by shifting the market.
Any questions for
Any other? Thank you.
Okay, so the original schedule had been going first before the local health improvement network leaders to kind of as an introduction, but now I guess I'm going to wrap it up. Okay, can we go to the next slide? So here's the definition for social determinants of health. I'm pretty sure none of you need to see the definition, but I think this is the first time we're actually putting it up there. So pretty much is the conditions, the physical and socioeconomic conditions we're born and live under. That's what determines our health, pretty much. So that's what we are trying to address with this almost $2 million that we have allocated through 2020. Okay, next slide. So here's the breakdown, pretty much. Almost $1.4 million going to local health. Oh, why is it coming up like that? Okay. Almost $1.4 million is going to the local health improvement networks, that's what they were talking about just now, these 3 LHINs. We have a total of 6 LHINs, and they're all going through this process of identifying their social determinant priorities. And $600,000 dedicated to the regional ACEs resilience campaign, almost $2 million total. So the way we went ahead to allocate the funds, we considered 2 factors. One, just the plain number of Medicaid consumers within each LHIN region, and the other factor is the severity of measures based on the Robert Wood Johnson Foundation County Health Rankings. And as you can see, this table correlates pretty well with the information Patrick provided us a while ago, pretty much the impact of economics on social determinants of health. So what we looked at here, we looked at each county, and the red those are measures in which that county is performing worse than the state. And the green is where that county is performing better than average within the state. So, and to make it a little bit more equitable, that's why we based it $1 million. Can we go to the next table? $1 million was based pretty much on, you'll see under population funds right there where the $1 million is at the bottom. That's based on Medicaid population alone. That $1 million was a percentage, based on the percentage of Medicaid population each local health improvement network had. The one right next to it, the WTSA, the worse than state average, that one was based pretty much on on the measures they had on the previous table. And that created a little bit of equity for the counties that don't have such large populations of Medicaid consumers, but they still have serious health measures issues. And you can see on the last column, that's pretty much what that particular LHIN is getting per consumer. You can see that the smaller the LHIN, the more it got per consumer. Okay, so we were pursuing equity by going that way. Next. And this is the last slide. I touched on the ACEs resiliency media campaign. It's pretty much a description of what that is. So we are GCACH. We are approaching health from all aspects, and this is one way. Also, the part of our social determinants, because ACEs, after all, they're just 10 additional social determinants of health. Any questions?
Yes. Just one comment to Patrick's point. I heard a talk actually the morning of the presidential election on the future of Medicare and Medicaid and social determinants of health. And the observation was that if you have to be poor, you're best off if you can do that in a rich liberal neighborhood. And you'll benefit from the neighbors, essentially. The idea that zip code is determinant.
That's not just true across income, it's also across race as well. Ms. Cap.
I just wanted to say that I think this is great information to share with the group, and I think it really reflects the arc of the work that's been done at GCACH over the past way in which we could embark upon an AIDS campaign 3 years ago. And so I think seeing it really come to life and be actualized is exciting and I think empowering for the work that we are doing. And sometimes it takes time, but it happens.
You're right. It's very, very exciting, especially seeing the caliber and the expertise of the people that are joining the task force. I think is tremendous. And one point that I forgot to mention, the Yakima County Healthcare Coalition's third-party administrator already got its $229,000, and same thing for Kittitas, third-party administrator, which is the same one. They also got Kittitas almost $100,000. And they will be, for Kittitas, they will be issuing RFPs in April, and they will be pretty much soon after, a few weeks after, they're going to be choosing who's going to work on the projects. Yakima, like Dan mentioned, they're done with the process. They got 23 applicants, and they will be starting to make those decisions pretty soon. And other lands are pretty close. They're getting there to start receiving funds and start working on these projects. Any questions before I pass it on to Patrick?
So I don't know, Carol, whether the other ACHs have anything akin to a LIN like we do. I mean, in part, the LIN structure was created to accommodate the real variation we have throughout this ACH geographically, and as I hope you saw from some of the information I presented, just socioeconomic status indicators. So, is there something like this going on in other communities and other regions?
I would say the majority of them have networks within their ACHs.
Okay.
They call them differently, but.
Right. Okay. So we are so efficient today that we're a half hour ahead of schedule. But I can't let you go. If you just give us another 5 or 10 minutes, we had to sort of cut off any further discussion on the PCCE evaluation, and I'd like to circle back, if we could, to those first two questions, Lauren, and see whether any of you who wrote those comments or ideas would just like to elaborate. So,
or Patrick, or any other observations that they might.
Or any other observation about the evaluation report. But can we go to? Can you bring up menti.com again, or? All right. The first question. There we go. So this was communicating to the community. Anybody want to elaborate on what they wrote? We have lots of suggestions, and this is going to take some sifting and winnowing on the part of staff to figure out where to engage. Any quick elaborations? Kat?
Well, I think I didn't write it, but the community newsletter piece, and I think this is connected also to sort of how people can understand what's happening. You guys do a great job with your GCACH director's report and that newsletter. And so just considering ways in which we can leverage that to share that more broadly, or however that looks, I think that that's a really good base of information and can also get people up to speed without having to dig through all of the different materials. So just that idea of board members are representing sectors, thinking about how you might be able to share those newsletters with other folks in your sector to bring them up to speed if they're just participating in the leadership council and not the board meeting as well. So I think it's just maybe figuring out how we can share that resource that you all do such a great job with more broadly.
Okay. Yeah. How many, just before we take those hands shot up, how many people are on the newsletter list? 700. Okay. I'm going to challenge you guys, since we create newsletters in a lot of our projects, to see whether you can go for more than that. And we try to use a 1% rule every community we're in. We want our newsletter to go out to 1% of the residents, which is a little different here, but maybe 1% of the Medicaid population. Think about what that would mean. It would be more than 700. Yes, ma'am.
I have a question. So when we say community, is it not, are we looking at all the community, not just us at this level? just send them this information if they're not able to comprehend. So I mean, if I'm doing outreach out in the community, really have to say it more simpler and make it more interactive, and so we're trying to have them understand and how it's going to benefit them in the long run versus what we're doing in this room.
So a very patient-centered communication, be it digital or be it written.
Yeah, or even like doing open-ended questions when you're out in the community, when you're trying to interact with them, try to get them engaged in the conversation. And when you do that, you're seeing, are they understanding what you're trying to tell them, and you kind of get it from there, like, okay, this is not working, then how else can we start to explain it?
Okay. Any quick reaction from staff to that comment about being out in the community and being able to respond in very simple terms? You think that could be done more often, or are there constraints for that happening? Ron, I got Dr. Kevin first, and then we'll get you. Kevin.
Adding on to that, the comment in the top left is mine. Outside of this room, the number of people across Greater Columbia who know that this organization exists, never mind what it does, probably numbers around a few thousand. Is that optimistically?
Optimistically.
No, I don't think that the public is aware of the benefits that are coming to them from this organization. And I don't know if that's putting up an orange stand at a farmer's market come spring.
An orange stand, you say?
Yes.
Oranges, piled up.
Making them not just what this group is doing, but the strong work that all of the different partners that are involved in this work, whether it be the lanes, whether it be the constituent organizations from VM down to the smallest provider that's participating, community paramedics. There's a lot of folks that are the fabric of the communities that are involved in this work. Everybody knows it. We want to get support from them. They might want to know what we're doing.
So I just want to drill down a little deeper then. How?
It could be, I could imagine brochures that I could put in the waiting room, in the front lobby of the firehouse, in the waiting rooms of our clinics, in the lobby at Hope Sports, or at County Public Health, that says we are a partner in the Greater Columbia Chemical Community of Health, working to strengthen the infrastructure and make Kittitas County a better place. I could imagine maybe it's a cheap PSA that just says, here's one of the projects we're working on, and here is a scroll of the 100 organizations that are part of this work.
Okay.
And what it means to your community.
Okay. Those are two good ideas, Kevin. Thank you. Rhonda. Ronnie, sorry.
All right, you got it. So part of what my thinking was is the brochure thing, but meeting people where they're at. So those are like community places, there's schools, there's the activity centers and places like that. Libraries, anywhere that people are going to gather, and that can be inclusive of churches, and reaching out to some of the leadership here in the community and places with brochures, but also having a return on them, because putting them out is one thing and the information is out there, but the other is what can they give us back that is not being met, and can you have a perforated section of that where their most needs are, and they can just turn it back into the area that they got it from. So like a box with a box behind it, if you want to do some kind of setup like that. But also, when you're talking about community activities, there's the flea markets. There's just imagine where if you put up a table somewhere, there's going to be questions: who are you? Why are you here?
Okay. Great. I forgot your name. George.
So I wanted to just kind of circle back to engage on community-based organizations. I feel like I feel that we need to tool when we're out there doing our presentations to our professionals, our agencies, our non-profits, is having like a short video that we can tag on at the end of our own. So I do 211. So I talk about 211 resources, but then I'm also an active part of the GCACH, next to show the video at the end that talks briefly about what they do, and then kind of give that push we want you to come to the table and be representative. I think that would be a big help.
Okay. Like a 30-second video that Kevin was talking about could be a PSA as well.
Yeah.
Right. Okay. Good ideas. Anything more? These are wonderful. Susan?
Not necessarily on that question, but kind of that question around what surprised you about the survey.
Yes.
What surprised by the lack of comments regarding the sustainability of the GCACH work. I don't, you know, I feel like there's a kicking clock. Like our meetings, there's a kicking clock. To the funding for this organization, I'm unaware that they find money in another place to come and replace it.
Right.
So I think that the timeline that we talked about before, how do the project timeline, how do the end time frame in front of us help to spur the work level to continue, recognizing that this is not a really long-term issue. We have this resource for a limited period of time. So let's use it for the most well.
So just to let everyone know, in April, the board meeting will be all about sustainability. We're having a retreat to talk about what is our future. So we will be addressing that very issue, and then hopefully from that we can present a long-term timeline and hand that out to the leaders.
I'm glad to hear that, because I do think that it wants to come from the leadership, and then the leadership council, we need to be on board so that when I speak with our agencies and work within the work group, we have it. Yeah.
Good suggestion, Susan.
So, yeah, maybe that can be on the agenda then you're suggesting for a future leadership council meeting, to maybe bounce off of what the board comes up with and what this group may want to offer in addition. Okay. Anything else from the survey? Because we got one more item I forgot that we want to get Lauren to talk about. So, all right. Well, thank you so much for those good thoughts. We all profit from, we're all smarter together when we have these kind of brainstorming sessions. All right, Lauren. Last but not least, Lauren Johnson.
I'm sorry. Did anybody have any comments on the phone that they wanted to give, Patrick?
I haven't heard anybody speak up from the phone, so if Carol just asked any of you listening in have some quick comments to the discussion of the evaluation of the ACH. All right. Hearing none. Lauren, do you want to just sit down there or Wes is going to run it for you? Okay.
He's going to drive.
There you go.
So it looks like Sandra had a question in the chat box, and all of the slides and the PDFs from today will be available on our website, hopefully tonight or tomorrow. So back in January, Wes and a couple other staff members came up with an initial list of the 2019 Leadership Council meeting topics, and I believe there are about 10 or so. And we took that list and put it into a survey and sent it out to our distribution list of almost 700 people. We're trying to improve that every day. But the survey window was from January 23rd through February 14th, so almost about a month. We received 27 responses. We were hoping for a bit more, but we're thankful for what we received. And the question we sent out was a one-question survey. was out of the topics listed, which are you most interested in learning more about at the 2019 GCACH Leadership Council meetings? And respondents were able to check the box for all topics they're interested in. So these are the top 6 categories. Out of those categories, the first was the healthcare workforce update. About 70% of respondents wanted to learn more about that. Next was the LIN activities, Local Health Improvement Network activities, and we were able to hear from 3 of our LIN leaders today. Hopefully we'll be able to get a couple more into the schedule later in the year. Next was the VBP update, and that, about 52% of respondents were interested in learning more about that. VBP stands for value-based payment. Next was HIT update, Health Information Technology update. 48% of respondents were interested in learning more about that. And then 41% of the respondents were interested in learning more about health equity and EMS and community paramedicine. And I believe EMS and community paramedicine is on the agenda for March. April. Okay, April. Next slide. So these were the last 6 categories that not as many respondents were interested in as the first 6 categories. But as you can see, 37% of respondents were interested in learning more about other HCA waiver initiatives and SWATCH, Early Adopter Experience, Southwest ACH, SWATCH stands for. And then 30% of respondents were interested in learning about the GCACH SIM project area and hearing from exemplar success stories. And I believe that's on next month. Okay.
For bidirectional integration.
If you didn't hear what, that was next month for bidirectional integration. And then 26% of respondents were interested in learning more about the organ experience and the OCH SIM experience.
And the OCH SIM experience, there's some project work around opioids.
And then the last question welcomed open text responses. If there's any other topics that you may be interested in that we didn't have on our plan for 2019. So the list is on the screen now. One of them, adverse childhood experiences research. We touched a bit on that today on the ACE campaign, but we will hopefully dive into the research in a later meeting. Social determinants of health research, how to get assistance in analyzing data, resolving data entry problems, respite resources, and then the top 3 are a bit long, but you can read those if you'd like. Are there any questions so far? If there's, go ahead.
No, go ahead, Laura.
If there's any other topics that you might be interested in learning more about, you can feel free to email me. I have my email address on the GCACH website, or I have a card. My name is Laura Johnson. We welcome all feedback. Thank you for your responses. Your feedback is very valuable to us. We want to make these meetings as important to you as it is to us to attend. So thank you.
We would like to show one more item. So on the CCHE survey, there was a question about the timeline and the project flows. I think we shared with the group last year, we had those blue boxes that kind of snaked around on the diagram to show the practice transformation project flow. It was very project management last year. This is 2019. It's daunting. And we're not going to go into details at this meeting. At a future meeting, we can talk about this more. The first horizontal row relates to patient-centered medical home and the learning collaboratives that are tied to that. The next one relates to Medicaid transformation project areas, which include the opioid abuse project and the transitional care project. After that, that middle row is all the HIT projects that we have going on. Below that are miscellaneous, which includes Ruben's ACES campaign, the Lynn Workforce project that Carol oversees, and we'll be talking more about that, as well as some special board meetings. The bottom row relates to reporting of our semi-annual report at the end of July, and that horizontal dotted line relates to the expected revenue accrued to us through incentive payments, which works out to be 17.5 plus $5.6 million. So just to address that concern, here's a response. It will be.
So, and maybe to respond to Susan's question, maybe we could go in very general terms beyond 2019 and just have that up there, just to see what 2020, 21. I mean, this ends in 2021. So, what do the subsequent 2 years look like in big steps? All right, we still might be able to leave a little early. There's no snowstorm to worry about. It's probably a nice day once you get beyond the Tri-Cities. And I know coming from Spokane, it was sunny, and we got the fog down here, which I was surprised at. But any last questions, last-minute questions for the good of the order or comments? Well, thank you all so much, and we will meet again March. What's that date? 19th. Third Thursday of the month.
March 21st.
March 21. So just like today. And so
It's almost as though we're 28 days.
there you go. No wonder. So thank you all online or who have been listening in on the phone, and we hope this has been a productive use of your time as well. With that, we're adjourned.